Good afternoon, everybody. Welcome to the podcast Digi4CARE. And my name is Šimon Jeseňák, and I will be your host today. And today we will speak about the first pilot of this whole project, and we will be focusing on the Fundus camera and on telemedicine stations in cardiovascular and diabetes for cardiovascular and diabetes patients. And I would like to welcome my two guests. The first one is Mira Ganova. Mira, welcome.
Thank you, Šimon. Thank you for inviting us.
Anytime. And the second one is Borbála, Bessenyey.
Of course, it's challenging.
It's challenging. This is the most spelling. I was trying to prepare myself, but we can call you Boris as friend Koli, right?
Yes.
Oh, thank you so much. This will help us a lot.
Hello to everyone.
So, Boris, let's start with your introduction. You are from Hungary, and what is your profession?
I graduated as a medical doctor, and now I am also a student in a health data science master's. But in my workplace, I'm working with digital health technologies implementation, which is also in this project, and I'm also working in screening program in Hungary and also with some basic research. So I have a little bit of many things at this stage.
But the professional of many faces.
Yes. I'm at the beginning of my career, so this is my first international professional project, and I'm very happy to be part of it, to interact with all the colleagues and learn all the difficulties and all the options that we have for Europe to transform the patient pathways via the digital technologies that we are testing now.
Thank you so much. Mira, what about you? You're from Bulgaria. What about your professional backgrounds?
Well, I'm from Bulgaria. I'm the Executive Director of Digital Health and Innovation Cluster Bulgaria. It's a community of digital healthcare experts. So we are the one national represented organization of the digital health industry in Bulgaria. So by digital health industry, I mean IT companies, healthcare professionals, pharma companies, all the experts that could add value with their knowledge regarding the digital health transformation in the healthcare. As a professional background, well, I have a lot of education and degrees on them, but my last one is a PhD. So I had the idea to go through the academic career, but since we founded the cluster, I switched my path. So, I'm primarily working and dealing with the digital health transformation in Bulgaria and abroad. And I may say that I consider myself as a healthcare and digital healthcare expert, but most over like a cause-driven person. I dream in innovation. I want to be part of a movement in Bulgaria and internationally, which leaves a legacy of a positive change for everybody, for the people, for the community, for the environment. I'm also a change maker, so I'm dealing with a lot of challenges in our environment. And yes, this is most over for me.
Brilliant introduction. Thank you so much. So let's start with the first topic, and that's diabetic retinopathy. Rory, as a medical professional and also a doctor, what is diabetic retinopathy?
Diabetic retinopathy is a condition that occurs with diabetic patients, and it worsens the state of the retina and the vessels in the retina, and it can cause a bad sight and also blindness at some point. So it is a potentially very serious complication of diabetes, and it is important to know that in Hungary, like every 10th person has diabetes, and in Hungary there is data on that the recommended screening is the minimum once a year for diabetic retinopathy patients. For diabetic retinopathy screening, and in Hungary, like maximum half of the patients visit an ophthalmologist regularly, and like 1 of 4 patients never in their life visited an ophthalmology for diabetic retinopathy screening.
It's strange. It's maybe even a little bit frustrated. And diabetic retinopathy, it's typical for diabetes of type 1 and type 2 or both?
It is in both cases, yes.
So you said that at least once a year, every diabetic patient should attend to visit ophthalmologists in order to be screened if they do not have diabetic retinopathy. You would have to describe why the percentage of the patients who attend this inspection is so low. What would be the answer?
To be honest, I don't have an explicit answer for that because it's a very, very complex question. It is also, we are in this pilot measuring why the patients do not visit ophthalmologists if they hadn't before. So at the end of the pilot, we will have some data on that regarding the population that we are involving in this pilot. But I would say that the main reasons for that is not very good compliance with the standard care. So you can say to a patient that, yes, please go to the ophthalmologist. This is needed for you, but they don't go. So there is a patient side. There is also a healthcare side. The ophthalmologists are very overwhelmed with work. We don't have enough ophthalmologists in Hungary. And it can be also hard to book an appointment and actually go there and wait a long hours.
Are the patients aware that they could lose a sight? Because for general person, it would be quite stressful to find out that with my diagnosis and with my medical condition, there is a real threat that my sight will decline or even I can lose a sight. But it is not sufficient reason for them to attend.
Or
to be compliant, as you mentioned.
Mm-hmm. Yes, we have a Pilot 1 leader. Her name is Dr. Dózsa Katalin Mária, and she is a GP involved in this project. She cannot be here today, so that's why I'm stepping in. But one thing that she always says is that there are many complications to diabetes. So less blindness is one of them, potential blindness, and people usually do not realize or don't think that it will happen to them because, diabetes doesn't hurt. It's a bit like hypertension.
And also the symptomatic, usually the diabetic patients, they have problems with the vision, So blurred vision, a little bit more low, low vision. And they may confuse those symptoms that are normal for their condition. Also, I want to add to Bori that the health literacy it's something that we should take into consideration because the diabetic retinopathy is a severe complication of the diabetes. So you should know your health. You should be aware with those complications, not only because your physicians it's telling you those complications, but because you should be aware of your chronic condition. The diabetes is part of the chronic diseases, and they're counting 70% of the Europe diseases are chronic ones. So we should know better, like patients, how to take care of our own health and be more responsible to this. And the type of culture in the different, countries, so less developed countries compared to advanced countries, we can see there big difference between the health literacy and the perspective of the patient. So in country like Germany, for example, the percent of the underdiagnosed patient with diabetic retinopathy it's less than in Bulgaria, for example. So in Bulgaria we have more than 40% underdiagnosed patients with diabetic retinopathy, which is a very, very high percentage of the population. To be unaware that they have diabetic retinopathy leads to blindness.
Yes, diabetic retinopathy is also called the silent thief of sight. So your words are just proving that this saying is probably plausible. Can we describe the early symptoms and risk of the late diagnosis? We have already mentioned that it's the loss of the sight or the fact that person is losing sight step by step.
Okay, I think we should state that none of us are ophthalmologists here, and we wouldn't want to interfere with their field. But sometimes it's not symptomatic, you know, because the periphery can be affected by this condition, and maybe you do not realize you are using both of your eyes, etc. So many of the patients go to the ophthalmologist only when they have symptoms, and then it's quite hard to adjust therapy accordingly. It is important to know that this condition is caused by prolonged time of high blood glucose level. So most of the time, collaborating with the GP or diabetologist who is taking care of the patient, you need to adjust the level of the patient's blood sugar very gently and very accurately. So it's a very hard process to go through, but that is one part. And then there are like other more advanced therapeutic solutions, for example, injections to the eyes, which are very expensive, and in Hungary it causes very big burden for the health insurance actually. So it takes up a lot of money.
The part of the pilot project related to diabetic retinopathy is also the term called Fundus camera. Can we explain what the Fundus camera is?
Well, it's special techniques for eye examination, not only for diabetic retinopathy, but for age-related macular degeneration and other related conditions of the eyes. So it's a normal fundus camera. What makes the difference here is the AI, which we are using to analyze the pictures from the fundus camera.
So it is sort of a regular camera that we can see in the ophthalmological offices.
Exactly.
But with the built feature of AI.
Yes, and the purpose it's only for screening. It's very important to say this, because all the certifications, so the MDR certification, the medical device regulation, when you apply for it, you should say what are the purposes for your tool, for your solution. So this solution is made for screening, and in this regard, I want to mention that if we have an early detection of diabetic retinopathy cases, it's 100% preventable. So as Bori mentioned, there is treatments. Different countries, they have different type of reimbursement of these treatments, but usually if we have, insurance companies or state health payers and got the early detection on time, the diabetic retinopathy complications are totally preventable and predictable.
In general, who can use fundus camera? Is it only ophthalmologists or GPs, so general practitioners, or maybe diabetes experts? Who can use it?
I think it's important to say at this point that I just wanted to add that diabetic retinopathy is not like 100% preventable in all cases, but we can work on the reduction of the state for the patient. But for the fundus camera, in Hungary, the traditional way is that the patient goes to the ophthalmologist, they dilate the pupil, which takes a lot of time, and after that, until the pupil adjusts again, it causes some symptoms to the patients. The vision is blurred a bit. But in this fundus camera that we are trying out in this pilot is a non-mydriatic fundus camera called. It does not need the pupil to dilate. So, and it's also a digital one, so we can have the picture recorded, because some fundus cameras are like analog ones, and they do not make the picture, in a digital way. So, like on the question, like who can use the fundus camera, my answer would be that it depends on the countries actually. So you have to check for the local regulations as well. We didn't spoke about it yet, but in this pilot there are 4 countries. I'm from Hungary, Mira is from Bulgaria, but we have a Romanian and a Slovakian site as well. But let's focus on our countries at this moment. So in a general way, it is intended to use for ophthalmologists to make a diagnosis on the fundus image. So it's a competency to the ophthalmologist at this point. And in this pilot, we are trying out the patient pathway, like how can you make this fundus camera, which doesn't need pupil dilatation, how can we make it work in a GP setting? Also in Hungary, there were some fundus cameras that are handheld, so a bit different, but the doctors already have it in their office, but there is no protocol how to use it. So that's what we are also figuring out at this moment in Hungary.
We're creating the protocol from scratch.
Not from the scrap, but
the patient pathway, yes. The patient pathway and how we deliver the care. Yes, we are redefining and reimagining it now through our project because, for example, in Bulgaria and in Hungary, the fundus camera and this solution is used by general practitioners. So we are trying to, and because the camera is very automated, so it's very easy to be used, by a healthcare professional. Not in
so it is user-friendly for the medics and for the patients as well.
It is very user-friendly. It is totally automated, so it's moving by itself, and it's very easy to be adjusted to the patient eye. And we are trying now to equip the primary care with screening tools that can support the early detection and diagnosis of chronic diseases and severe complications. So this is our primary idea because when we screen the patient, and it's very applicable for national health screening programs, because you can do it at larger scale, for example. Because as Boris mentioned, the ophthalmologists, they're too pre-booked and overwhelmed with a lot of patients. Also, the conventional examination is taking more time, to dilating the pupilla, to wait. It's a process. You are dropping, drops 3 times to dilate the pupilla. So the conventional methods, it's a little bit slower and tougher for the patient and also for the physician because it's taking time. And with these solutions, we are trying to screen a big population of diabetic patients, and those who become positive for diabetic retinopathy, they should go to ophthalmologist and be checked by conventional methods.
So basically, it is not yet decided if this diagnosis should be at one spot, that it could be ophthalmologist, it could be diabetes doctor, diabetologist, or it could be general practitioners as well. So it's up to every country and their legislation what they will decide.
Well, I would say that yes, it is. So we are in this pilot. We are producing reports and scientific.
Evidence.
Yes, thank you. Evidence for Hungary to support the board of ophthalmologists, the board of diabetologists, and other professionals as well. So they can make, if they want to, based on the results, make a modification to the guideline, like how we should proceed with this kind of patients, because it is important that everything that you do, we are not in a pilot study, so that's why we are using it, but for the conventional use, it should be incorporated into the guidelines. And I also wanted to say that it is also not like a final state of the pilot, whether it should be in a GP office or it should be in an in the optics, because patients also go there very often, or maybe in some of the ophthalmologists instead in the diabetologist office. So it's also in the making of process now, and we are contributing with what we can do in this pilot.
If you would have to simplify the project goal, what would be the answer?
Well, to validate and introduce new innovative solutions for general practitioners for primary and secondary care. We for me, the leverage of this project is first the adoption of new technologies and solutions, because, for example, in Bulgaria we are not early adopters. So it's very difficult, to convince healthcare professionals, educate and train nurses to operate with new technologies, with digital solutions, with additional software systems, and be confident that they're okay with them. So the adoption level, it's our primary goal. Also to highlight the benefits from the new technologies and how useful they could be to the effective and informed decision making for the patients, because if we can screen big population for diabetic retinopathy, for sure we are supporting the whole patient pathway and care delivery in the country. We have more patients that are screened, so more patients are going to be directed to ophthalmologists and pass the conventional examination, and more findings we are going to discover that way. So a lot of leverages and benefits we are having in this project, but for now the new technologies, the adoption, the development of new type of skills, capacity and mindset within the healthcare field, it's very important for us.
In order to technology or drug or anything in the medicine can succeed, it is important to be beneficial for the patient, beneficial for the doctors and for medicine and for the payers. So we will have to start with the patients. What is the biggest advantage for them?
Well, at this point, I think I would say maybe time and access. So
Is it pain-free?
Yes, it is pain-free. You see,
because many people, including me, are scared of going to doctors because we are afraid of pain.
In our case, if you go to the GP, then there will be other examinations done to you. But if we are talking about the Fundus camera, it is pain-free. You see a bright flash when they are making the photo, but that's it basically.
So you maybe get scared a little bit and move backwards, but that's it.
No, you don't feel it.
You don't feel it, but you see it a little.
Yeah.
It's very fast flash.
It's very fast flash, so you cannot react.
Okay, and the advantage for the GPs, for ophthalmologists, for diabeticians, what would be the answer?
So
it's time saving. It is.
It is, for sure. As Bori and I already mentioned, those type of examination, it's a screening tool. So the ophthalmologists, they want to make their conventional examination because it's related with additional lab tests and additional activities during this examination. But on a national level, to have such a tool like a screening solution, it's priceless, because we can make this triage of the patient. So we may say these patients are positive, maybe are positive, these patients for sure are negative. Of course, there is a small percent of false positive and false negative results, like always, but when a human is interacting, also we have such cases.
False positivity,
yeah, of course. So it's technology, it's a very small percent, but we should take it into consideration. But yes, it's a very it's saving a lot of time for the examination, and it could be made on a large scale, which it's not feasible if each patient should book an appointment for ophthalmologist. In Bulgaria, it's not feasible because we do not have enough medical specialists.
Or how are we gathering the data, and what are we doing in order to collect the data from the various countries related to the pilot number one?
If we are thinking about the pilot, which we are doing, it's important that we are making in Hungary an observational study, which means that the patient pathway at this point is the same. So everyone goes to the ophthalmologist. We are making this additional examination, and both of the patients are directed to the ophthalmology. It is important to say at this point that we have these institutions like the Semmelweis University, that's my workplace as well. I'm working in the Health Services Management Training Center, and we have very nice collaboration with the Ophthalmology Clinic of Semmelweis University. So thank you for your collaboration and all the help that we are getting from you. So the data is collected for this study on the site of the GP, and it is pseudonymized, and the patients are aware of how we handle the data, and they of course sign a consent paper for everything that is happening to them.
It's the same case in Bulgaria, so we are following the same patient pathway. So we are gathering diabetic patients from the cohorts of the GPs, and they are directed to a specially equipped cabinet with those for diabetic retinopathy and cardiovascular disease evaluation and screening. And if there is a positive patient, it's addressed to an ophthalmologist.
Were there any technical or practical challenges during the implementation of the pilot that has arisen in both countries?
I have one that I can mention, as you're asking. We had problems with the Wi-Fi connections, so the Fundus camera and our other technology for cardiovascular disease evaluation of risk patients we are going to talk about in a bit, they're connected through Bluetooth and Wi-Fi.
Both at the same time?
Yes. I cannot explain exactly the connectivity type of things, but we had to have very good Wi-Fi, or to plug in a cable of the VPN, the internet, so to ensure good connectivity of the Fundus camera. And we weren't prepared for this, because in Bulgaria we are executing the pilot in a municipality outpatient clinic, so the Wi-Fi coverage wasn't so good, but we managed it. So now everything is okay, but we for next pilots, projects, and this type of activities, we are going to be aware of the connectivity issues.
What about the project in Hungary? Potential issues that you've been facing?
I think it's important to state that we are making feasibility studies. We have a lot of feasibility questions exactly for these kind of reasons, like what are the obstacles, and we are collecting data on what is the experience of the doctor who is implementing it. For example, we have questions on how much space the camera needs, what kind of table you need for that to operate. So yes, I would say about technical problems, we had also Wi-Fi issues, of course. We had some problems with interconnectivity with the Fundus camera and the software that we are using. And also I would say that the ideal conditions are some kind of a problem, because in many cases in Hungary the GP offices do not have like extra rooms to use. So you have 1, 2, very maximum 3 rooms that you can use. But in Budapest, for example, many of the GP offices have only 1 room that they share, for example, with another doctor. So
and maybe there are small ones.
And there are also small ones, so you need a separate table for that, a relaxed setting, and so I think the infrastructure comes here when we are implementing these kind of devices.
The crucial part of the pilot one is also telemedicine stations for the cardiovascular and diabetes patients. So let's talk about this part, Mira. You can start.
Well, when we started the project, we wanted to cover, chronic diseases. This was our primary care, because in our other pilots, we have continuous monitoring and continuous medical care for cardiovascular patients or comorbidity patients with diabetes and cardiovascular conditions as well. So we wanted to cover these type of diseases, like they have a very, very big privilege as percentage for the whole population in Europe.
And is rising. in addition?
It's arising and it's very demanding, because it's not just a current state or a current condition that you take a pill and you're okay after, a flu, you're okay after 1 week or 7 days. But you should live with these conditions. It's a chronic one. So
you should and you will.
Yes. And we wanted to take care of those patients. Also, we very well understand the problem with the underdiagnosed patients. For Bulgaria, for example, we have a lot of underdiagnosed cardiovascular conditions, because they could be confused again with the symptoms, or how they feel, and the pathology of the heart. So they're very, very complex and complicated conditions, the cardiovascular ones. The diabetes also, it's a metabolic problem and could be confused with other, conditions. That's why we have underdiagnosed patients as well in this field. And when we started the project, we say, okay, let's find the solutions, how to screen and evaluate risk patients. How we can make this to tell the patient, well, see, you are a very risk patient because you have this factor, this risk factor, and you should go to a cardiologist, or you should take, measures and actions for yourself. So we found solutions back then when we started the project. It's a very comfortable telemedicine station. It's like a massage sofa, it looks great, and it's very comfortable for the patient. So we are measuring with this telemedicine station, we are measuring up to 15 vital parameters, and we are taking a lot of digital biomarkers of the patient, from the patient. So we
How do you do that? Through the machine?
Yes, through the machine. Like I said, it's a chair. So we are taking blood pressure, ECG, 12-channel ECG, which is very informative, like data for the patient. We are making rapid blood test for lipid profile of the patient, so the cholesterol and the good one and the bad one. And after we are taking all these 15 vital parameters, also we are gathering information for the patient about tobacco consumption, alcohol consumption, physical activity, and so on and so on. We are mixture this data, and we are evaluating under score 2, which is the European certified score for cardiovascular risk patients. And we are telling this patient, you probably, because you're with a very high risk and you're red, so you probably have underdiagnosed cardiovascular condition, and you should go to your general practitioner, or you should go to your cardiologist, but for sure you should check yourself about the
So it is also
condition.
the way how to prevent the illnesses to even occur, or to catch it soon enough before it could be, in some cases, even fatal.
This is the main idea, yes, the prevention measures that we should take to prevent diseases and predict them better. This is our primary goal with the cardiovascular diseases. We have a lot of cardiovascular deaths due to cardiovascular conditions. We have a lot of underdiagnosed patients. Cardiovascular conditions are very broader, they're very complex. Often they're not diagnosed correct. Like condition,
And soon enough. Sometimes they are diagnosed
enough.
after the first heart attack, which is
Yes.
way too late.
A lot of patients, they are not aware that they are they're risk ones, because of obesity, because of smoking, because of alcohol consumption, and all those risk factors are leading the patient through a risk cohort, a risk group. And all the patients should be aware that they should go to regular checkups, to take care of themselves, to be more sensitive for them own health. And also we are trying to support this effort through digital technologies, introducing them within the primary care. We are working with general practitioner for cardiovascular disease, also to take all these all these results and data for the patient, if we are going to take them by the conventional way, it's taking a lot of time. So with this telemedicine station, it combines, for example, 5 medical devices in one. And this allows us to be more precise, more fast, and to communicate better with the general practitioner, because the general practitioner is receiving all the data, accumulated data, very in a structured way. So the general practitioner is seeing all the parameters very structured, and we can support that way the informed and effective decision making.
Where are those chairs placed in these days?
Well, together with the Fundus camera, we equipped a dedicated cabinet in one of our outpatient facilities. Municipality facilities is 12 Diagnostic Consultative Center here in Sofia. So we are supported by the director of the center, and we are very welcome to introduce new technologies there. We are working there with 3 general practitioners, also with cardiovascular specialists and ophthalmologists for the whole value chain of the project.
Great. We want to add something?
No, thank you. We were there today to check the screening station for them. It was very, very nice to see like how automated the results go into the system, like from the blood sugar monitor that measures the blood sugar. It's automatically there on the chart. So in medicine, this really saves time, you know, because the professional...
So it is extremely effective too, how in order to reduce also the visits of the doctors.
Yes, for sure. Yes. For sure, because if a doctor should perform such an examination in their office, it's going to take him or her about hour and a half.
Yeah, I wanted to say 90 minutes.
Yeah. Something like this. Plus
the time of the laboratory that is going to take the example and evaluate it, etc., etc.
You mean in a conventional way?
Yes.
Maybe a day or 2, depends on the laboratory, because if it's a conventional one, not a rapid test that we are using, it could take 1 to 2 days for blood sugar or for cholesterol and related laboratory
What
tests.
is the reaction of the patients in general towards this chair? Because they are used to the fact that they come to the ambulance and there is their doctor that they are visiting for past 30 years. There is the nurse who is maybe co-students from the school, etc., etc. Don't they miss a human contact?
No, but there is human. The examination is performed by nurses, so they are feeling comfortable. Also, the cabinet, the office is within a healthcare facility, outpatient healthcare facility, so they're feeling confident with the examination. But most over, to go to a doctor, whether if it's a specialist or a GP, it took a lot of time for any patient, because you should book an appointment. Very usually the appointment, it's not very, strict like time, and so on. And with this chair, the patient is coming, it's examined no more for 7 minutes. We are taking all these results, as Boris said, everything is automated, and this is saving us a lot of time, because we are measuring everything, in a certain way, and all the data from all the measurements, ECG, blood pressure, blood sugar, lipid profile, and so on, are automatically implemented into the system, into the software.
How is it evaluated, or is there a cross-reference or cross-check or a double-check of those results? You know what I mean?
I know, but for this system it's not necessary, because it's fully certified, like CE mark, like medical device, so they've already passed all the validation tests and calibration tests compared with conventional methods, and the accuracy is around 98% compared to conventional examination.
And what are the reactions of the patients so far?
they're very positive because we are saving them a lot of time, and also they are receiving all their results first in two ways. We can send them all the results via email. So if they leave us their personal email, everything is there in a minute. And also we are connected with the National Health Information System here in Bulgaria. So if the patient has downloaded his personal electronic health record, the results from this screening and for these pilots goes directly to the National Health personal, record.
I think for the diabetic retinopathy screening program, what we have experienced so far was absolutely like enthusiastic people, patients, and also the doctors that we consulted with were also like open and positive about these kind of solutions. But I think it's important to put here at this point that using an AI technology for screening or like final decision making is in the EU, according to my best knowledge, like not well incorporated the technology so far. Probably it will have some good practices in the next few years, like how you are working with the question of responsibility, etc. with this AI. So I think it needs to be solved when we are using AI technologies in medicine. But for our pilot and for the opportunities with AI in a screening system, you can use it, for example, as a second opinion to better to help the physicians to diagnose the picture that he or she is seeing. It's not part of our project, I'm just telling it. Also, it can be like, for example, a definitive solution. If the AI says no, then it is really like a negative result. We are not there yet in Hungary for sure, but we are making a step towards explaining like how you can incorporate this kind of results better. Yes.
All technology could be like a best friend to the doctors, to the healthcare professionals, to amplify all the decision making and support the effective decision making. This is the purpose for the technology. The technology cannot replace physicians. At least all the data, all the parameters should be annotated by a healthcare professional. If we want to train an AI on certain diagnostic approach or something like this, we need a physician to tell the AI this is wrong and this is okay. So we need physicians to educate AI and to go hand by hand together for this effective early detection, early diagnosis, and this informed decision making by patient.
But in general, those technologies can really boost up the accessibility of the healthcare also outside the Western civilization.
For sure they could, and they will.
Hopefully soon. Mira, Ganova, thank you.
Thank you, Šimon.
Borbála, Bessenyey, thank you for coming.
Thank you, Šimon.